So I don't have any relevant financial disclosures. I also am going to be saying something. I mentioned this at the last training as well, which is that I'm going to be saying some things today in this talk that I've, I think, I hesitate to say the word iconoclastic, but we were talking about it because I'm kind of trying to look at the co-occurring disorder issue in sort of a broader lens. But that being said, I want to make sure that people understand that I'm not speaking from a particular vantage point in terms of like someone else's official position, like any of my, what seems like now 6 different employers. Okay, so let's start with some definitions just to kind of get this off the table, which is, what is a co-occurring disorder? How do we define what a co-occurring disorder is, or a COD, for those of you from New England, not to be confused with the fish. But co-occurring disorders, having one or more disorders. Okay, so alcohol and or drugs of abuse and one or more mental health disorders. That's sort of the textbook definition. In terms of adding on to that co-occurring disorders, at least one disorder of each type can be established independent of the other. So not clusters of symptoms from one disorder. So we're starting to set the stage here and kind of thinking about conceptually one of the things that in part I want people to start to think about moving away from, which is thinking about siloing, thinking about the idea that we look at each thing that the person presents with in isolation from something else that they present with. I think that's been part and parcel of our training in medical training up to this point, and it serves a good function in certain settings. I would say in an ICU, you have to have a problem-based approach to multiple organ systems to be able to address this issue, that issue, this issue, that issue. My experience with working with systems around co-occurring disorders, and that's primarily what my role is professionally now, is kind of working with systems around how to deal with co-occurring disorders, is that the ICU approach falls a little flat in terms of what people are actually looking for and what they're actually trying to get out of like a psychiatric consultation, for example. And more importantly, very infrequently does a patient come in and say, I have this discrete problem, this discrete problem, this discrete problem, along a behavioral health spectrum. Like, I have moderate alcohol use disorder, plus I have some schizophrenia, I have some of the, very rarely do they come in and partition that out. They're in part because their experience is not of each of these things as being independent. Their experience is these things are in totality. And I'm going to try to expand that out even beyond this definition as we move forward. So some other things that I like to kind of put out there, and again, for the people who have seen pieces of this talk before, I like to say that we're all in the behavior change business. Now, I say this like, if you really think about it, even a surgeon is in the behavior change business, even though they might fight against that to some extent. We are all in the behavior change business. In other words, if we're treating a patient with diabetes, if we're treating a patient with depression, if we're treating a patient with alcohol use disorder, we are treating people and we are working with people to help also institute behavioral changes that will lead to long-term symptom relief. It's not just about an intervention that has no other sort of behavior change component to it, and especially when we're talking about co-occurring disorders. Now, for this talk that I've given to audiences that are not simply, for audiences that are more outside of psychiatry or psychology, this next slide is one that's sort of a call to arms to other disciplines besides psychiatry and psychology. But for us psychologists and psychiatrists, please don't take offense to this, but there's very little that you absolutely need a shrink for. And I let that sink in for a second. In part because I do think that the vice versa is true as well. That for psychiatrists, there are lots of things that psychiatrists can do that don't technically fall into the DSM. Now, again, the idea being that as a psychiatrist, like, I'll often be advocating for a particular medical workup, or I will be pushing for a particular set of labs to be drawn, and I will elicit some help from my medical colleagues in interpreting those labs, but understanding that some part of this is also my responsibility. Some part of this is also part of my work, is to understand that there are medical pieces, there are psychological pieces, there are social pieces, and as a result, I have a responsibility and an ability to look at these different pieces. When I am consulting to health systems around, I'm smirking at this one because this concept really started coming out when I was in consult work a few years ago, which was that more often than not, the thing that is going to come up time and again from different people is personality disorders. And I think it's important to understand that the way I have it phrased here, what's really going to bother you are the personality disorders. To put this in context, it's more about what is going to bother your colleagues and what they're going to call you about, or what other people are going to approach you about with your patients with addiction. Is they're going to say, well, but they've also, they're doing this, they're doing that, they're doing this, they're behaving in these different ways. And as a result, they're going to get labeled with personality disorders, right or wrong. But the challenging part about that is to understand that, for most behavioral issues that people clump into personality disorders, we don't have a med for that. Right? As much as we would love to have a pill that we could give someone with antisocial personality disorder and it will change their behavior, we just don't have that. So a lot of what we do when we're talking about managing co-occurring disorders in patients with addictions, mental health issues, other issues, is that we're actually also working on treating the system and how to approach them in a way that can move their behavior in a particular direction that's more adaptive and less maladaptive, if that makes sense. Okay, I got a little out there on that one. So I'll bring it back down to earth with a cartoon. People that can't read this is the mouse talking to the dog, and the mouse is saying, remember, the enemy of your enemy is your friend. So, where am I going with this? One of the places I'm going with this is to help understand that the system is the enemy in some ways. That we all are operating with patients in a system that does a certain thing around the concept of co-occurring disorders, which is that it divides us up. Now, these are all silos. Is the best graphic I could get for silos. But the idea here being that that all of the different systems that we deal with parse things out between this is a mental health issue, this is a substance use issue, this is mental health, substance use. So, some of these acronyms are more familiar to me because I'm kind of working in the public sector.
ODS.
So ODS is Organized Delivery System. The Organized Delivery System is a California-specific expansion to Medicaid. This was when ACA was enacted. California's Medicaid system, which is known as Medi-Cal, applied for and received a waiver to expand their billable services to Medicaid around substance use. The program that implemented that statewide was called the ODS, or Organized Delivery System, right? But that's just around substance use, right? So right there, we're talking just, these services are just billed for separately, and they are treated separately by different staff, by different contracted providers. All the funding streams are separate from mental health. So again, thinking about silos, you've got Organized Delivery System. We have, in the county level, we have alcohol and other drug systems. So basically in each of the counties in California, this is another talk that I give at a different time, but all the counties in California, the Medicaid services are divided up between medical and behavioral health. And behavioral health falls to the counties. It's their responsibility for Medicaid services in the county. For behavioral health, most counties divide that up, and they have an alcohol and other drug system, and they have a mental health system, or specialty mental health system. Again, two worlds, separated out, different funding streams. What does this look like to the provider? The provider sees a patient. The patient isn't divided up. There isn't sort of like 3/4 of their clothes are specialty mental health and 1/4 is alcohol and other drug. But the provider then is being told by the system, you can bill for and see this part of the patient for this service, and then this other part of the service, the alcohol and drug service, has to come through a whole different channel, and you can't do that. Again, the messaging being you can't do both, right? So Add some national complexity to this. We've got, I mean, I won't go through all of these, but we've got the National Institutes of Mental Health. We've got the National Institute of Drug Abuse. We've got NIAAA. Again, there's a parsing out that sends a message around the fact that these are separable and that they should be looked at separately. On the clinical level, and I'll keep coming back to this point, again, the patient's not coming in saying that I have these separable illnesses. The patient's usually coming in saying, this is me, and I have this spectrum of symptoms. And when you put a lens on it, or the system is telling you to put a lens on it to look at these things separately, it starts to make it then a lot harder in many respects to actually treat the patient and figure out what you're going to do next. So this is a very important graphic. It is from my blue period. This is actually the cover of the Facing Addiction in America Surgeon General's report. Okay, so something got lost in the translation there. But a quote from that is that integrating services for primary care, mental health, and substance use-related problems together produces the best outcomes and provides the most effective approach for supporting whole person health and wellness. Okay, so again, now we've got the system on one hand is telling you for billing purposes and for documentation purposes and for how you structure your appointments and where people get seen, these things have to all be separate. Then you've got other parts of the system that are telling you, wait a minute, we should integrate these all. We should do these all together, right? And I'm going to come back to this concept of integration in a second. But just as a breather, we're going to do a quick exercise here. True or false? Supported scientific evidence indicates that closer integration of substance use-related services in mainstream healthcare systems will have value to both systems. True or false?
True. False.
It is true.
Is there no data? I'm just wondering if there's enough data on it.
Well, I pulled this from the Surgeon General's report, so I myself haven't looked at what they cited as that, but as a concept, that's what they said, that the evidence supports it. So true or false, substance use disorders are medical conditions and their treatment has impacts on and is impacted by other mental and physical health conditions. True or false, supported scientific evidence indicates that again from the Surgeon General's report, that individuals with substance use disorders often access the healthcare system for reasons other than their substance use disorder. Many do not seek specialty treatment but are overrepresented in many general healthcare settings.
So true.
True. Seeing a trend here. Supported evidence indicates that one fundamental way to address racial and ethnic disparities in healthcare is to increase the number of people who have health insurance coverage. Okay, and I'm going to come back to racial and ethnic disparities in a minute. Well-supported evidence shows that the current substance use disorder workforce does not have the capacity to meet the existing need for integrated healthcare, and the current general healthcare workforce is undertrained to deal with substance use-related problems. True. So, healthcare now requires a new, larger, more diverse workforce with the skills to prevent, identify, and treat substance use disorders, providing personalized care through integrated care delivery. This wasn't a true-false, this was just a statement, kind of wrapping up on that, or following up on that. Okay. For those of you that have seen this talk before, this is where heads will start, spinning on their axes, but I do want to introduce, for people that are, again, kind of back to this idea that when we look at co-occurring disorders and we think about treating co-occurring disorders and we think about the concept that in many instances we're having to actually address the system-based issues that make it difficult to treat things as a unified individual. It's important to understand how the system works, and I think that in particular this Medicaid system is a large system which may get bigger. I mean, I can't project what's going to happen politically, but suffice it to say it has increased in its size and scope over the past 10 years. And in California, certainly where we're practicing now, I introduced the idea that Medicaid as a state program is Medi-Cal, and that it is divided up amongst a lot of different organizations in very unusual ways. And I'm going to try to simplify it as best I can by working through a little flow chart here. Okay, so is everybody buckled in? This gets complicated quickly. Okay, which I think is probably like a pedagogical no-no, is to say this gets complicated really quickly, because half the people probably, oh no. Okay, Medicaid is a federal program, okay? Which means that in its origin, it starts at the federal level and money is allocated at the federal level for providing funding for Medicaid beneficiaries in the country. Now, however, the federal government did not want to own all the responsibility about this, so what they did is that they said, well, if you, the individual states, want to have access to these resources, you need to have your own state level system that you're going to contribute your own money to as well, and that you're going to abide by the rules that we set federally, and we're going to audit you, and we're going to follow you, and we're going to kind of make sure that you're in compliance with all of our rules and regulations. But it's supposed to be a partnership between the federal agency and the states. And in its origin, it was very limited in scope. And in fact, in its origin, there was very little in the way of substance use services that were provided for within Medicaid. That expanded, as I mentioned earlier, around the organized delivery system in California, but it expanded with the ACA. So the ACA opened up the opportunity for additional funding to be available for substance use treatment services. So when this system gets kind of partnered federal and state level in California, it becomes called Medi-Cal. Has anybody heard of Medi-Cal? I know you're working in the VA, but most people have heard of Medi-Cal. And if you haven't, when you leave the VA and you go into the wide world, this concept will continue to come up time and time again. Okay, so how do we divide this out in Medi-Cal? Now, in Medi-Cal, we have the medical benefit. So there is a medical benefit within Medi-Cal. Those are typically managed by what we call managed care plans. Now, in San Francisco, being a big county, city and county, San Francisco has, I think, 2 or 3 of their own managed care plans. Healthy San Francisco, I know there's at least 2. For Marin County, where I am, there's an organization called Partnership Health Plan. All this to be said, there is a managed care organization that is given money by the state to administer the medical benefit to beneficiaries in their catchment area. So in San Francisco, if you have Healthy San Francisco, that's your managed care plan for your medical benefit in San Francisco. So if you're a Medi-Cal beneficiary in San Francisco and you break your leg and you go to the hospital and you get services provided, the hospital is going to bill someone. They're going to bill Healthy San Francisco because Healthy San Francisco is getting money from the state and the feds to cover that benefit. So within the medical benefit, though, there's a medical care benefit and a behavioral health benefit. Wait a second, I told you before that the behavioral health benefit is separate. Well, no, some behavioral health is administered by the medical plan. And this is where heads start spinning, okay? Within behavioral health, you've got medications. Your MAT, your psychiatric medications can all be administered through and paid for by the managed care plan. However, the way the state looked at this and when they constructed this is they said, well, we're not going to make the managed care plans responsible for all behavioral health. We're just going to make them responsible for what's called mild to moderate mental illness. So if you have mild to moderate mental illness and you report to your primary care physician can write for an antidepressant, bill for that service to the managed care plan, and that's it. However, if you have mild to moderate mental illness, according to the state's definition, you can't get counseling through the managed care plan. You can only get med evals and med appointments through the managed care plan. So you can start to see where I'm heading with this potentially, which is that, so now you've got someone, let's say with alcohol use disorder, who has depression, who's going to their primary care physician. Primary care physician says, I've identified alcohol use, so I'm going to start you on naltrexone, right? We know that that's covered, but we'd also like for you to get counseling around your alcohol use disorder. Oh boy, where are we going to do that? Because we can't actually do that. We can't bill for that. So what are we going to try to do? We're going to try to refer them then to the county. So this is where you start to hear this dialogue around county versus not county. Again, you see a little bit less of this in the VA. But around you right now, this is a conversation that's happening constantly. Is sort of who's responsible for what, in part because of this distinction around mild to moderate mental illness. So the county says, well, is it really us? Like, is it really our responsibility to do the counseling for this? I don't know. They have to come through our system, be evaluated, and we'll make our own determination. So now the client has gone to 3 different places, starting to get frustrated, maybe has low distress tolerance to begin with. And now we're saying, like, you got to go to 3 places to get evaluated to figure out what services you should get. Because the county says, whoa, whoa, whoa. State says our responsibility is serious mental illness. Depression isn't serious mental illness. We cover bipolar, we cover schizophrenia. And we don't cover, through that benefit, we don't cover necessarily substance use disorder, okay? So this, if I can distill this down, and this is sort of like 5 minutes on perhaps one of the more complicated things that I've ever had to try to wrap like ICU management of complex lupus with multiple organ failure is probably easier than understanding this. This is where if I could highlight an area, I don't want to stand up and lose the camera. If I could highlight an area where most of the problems exist in terms of access to services around co-occurring disorders with people in the bulk of California, it's going to be right here, which is some people are going to think they have serious mental illness, some people are going to think they have mild to moderate mental illness, and they're going to dig into their trenches, and the net result is that the primary care doctor is going to be sitting there, I'm pointing to you because I know you're internists, but like primary care doctor is going to be sitting there and saying, well, what do I do, right? Like I'm stuck, or the psychiatrist, and then on the other side is going to say, well, I'm stuck. How am I supposed to treat this, right? Again, back to this notion that the system is telling you that you can't do co-occurring disorder treatment simultaneously. I see Dr. Baki is smiling. Some thoughts about this, I'm sure, some comments about the system in general. So why do we get stuck in this situation? I'm not going to go into great detail about this, but I wanted to put it up there, which is that there are guidelines that people are supposed to be using to determine what's mild to moderate versus what's serious mental illness. And it's a medical necessity determination, and different parts of San Francisco County, whether it's through TAPS, is it still TAPS?
Yeah.
Or through other systems, are deploying these criteria to kind of figure out, like, okay, well, is this mild to moderate, is this severe? Again, there's a lot of money on the line, depending on the outcome of this determination. And in many instances, this determination is not being made by physicians, for example. And that's not to say that other people besides physicians can't make these determinations, but you can see that there's a ripe opportunity for difference of opinion about what the diagnosis is, and that there's a lot on the line depending on how someone defines this. So substance use disorders are not covered diagnoses when it comes to thinking about the clinical determination of medical necessity. Because remember that you have to have all 3 of these. The first one is that the beneficiary must have a diagnosis covered by Title IX. So someone that walks in with a horrific, I'm using sort of exaggerated terms, a horrific, this is not a DSM term, horrific alcohol use disorder, right? That by all accounts, they've been admitted, you have to remove all the hand sanitizer from the floors, people have experienced this. Technically, that's not a diagnosis that's covered in Title IX. Therefore, they can't meet medical necessity for having a serious mental illness. This is part of the reason why you hear people in San Francisco certainly complaining about, why can't we conserve Joe with a serious, with a horrific alcohol use disorder? Part of the reason is because the county will say, well, it's not really our responsibility because it's not technically a serious mental illness. And then the health plan will say, well, it's technically not our responsibility because we don't technically do, we don't typically provide other than medications, services for alcohol use disorder. So again, now you're back into this bind of like, well, what's the client going to do? And again, the individual provider, the internist, the psychiatrist or whatnot is getting the message, I can't treat this piece. I have to only treat this piece. Okay, this I'm just gonna kind of fly over very quickly. This is just a blow up of describe on more specifically around the behavioral health benefit that the counties have, and people will have access to my slides or if they want to ask me more questions directly about this. But my guess is that most people's heads are already full trying to understand the sort of last flow chart, because I don't even completely understand the last flow chart, and I put it together. So places to get psychiatric and substance use disorder medications. Again, this is coming back to this idea that there's a parsing out, and that there are different places where people will say they can get their medications and other places that say that they can't get their medications. So it's not one-stop shopping. The reason it's not one-stop shopping, the reason why it seems messy and hard for clients to kind of get into getting the medications that they need is for all the reasons that I just mentioned, which is that different people see different responsibilities around the meds based on the diagnosis. Is it mild to moderate? Is it serious? Again, I don't want to harp on this because I know heads are spinning. So I want to think about then kind of pivoting into this idea of integrated care. And this is somewhat of a loaded term that I feel gets, even the Surgeon General's report talked about the benefits or the merits of thinking about integrated care. What is integrated care? We're going to unpack that a little bit because again, I'm coming back to this idea that what happens is that people will come in with multiple different symptoms and they'll get labeled with co-occurring disorders. And then there'll be an issue where the primary care doctor, for example, will say, well, listen, I don't have mental health here. I have to refer out the mental health. And then someone else from the administrative side will say, well, wouldn't it be great if we had integrated care? Wouldn't it be great if we had integrated care? If we had everybody in the same room together and treating all the same things at the same time? I'm going to come back to that because it's kind of a cliffhanger. So it sounds nice, right? Well, a lot of places think that they do integrated care. They say they do integrated care, or they have some metric that they judge themselves by and say that they're doing integrated care. What is integrated care by definition supposed to look like, or what are the components of integrated care? Kind of thinking of the hierarchy here, you've got kind of at the beginning, integrated care, you've got motivational interventions, outreach, time unlimited services, stage-wise interventions, integrated treatment specialists, and then finally, at sort of the top of the integration sort of pyramid is multidisciplinary teams that are evaluating and working with patients. So that's sort of like, what does it look like? Some added elements to managing co-occurring disorders in terms of integration would be thinking about incorporating pharmacological interventions, alcohol and drug peer, self-help groups, family interventions, group treatment, substance use counseling, promoting general health. Okay, these are kind of domains within which going back to the last slide, a multidisciplinary team might engage a client. And that people would say like, okay, well, given this, most of the programs that say that they're providing integrated care, are they doing all of this? Maybe some are. But in most systems, and I can say certainly in most systems that are outside of major cities, aren't providing all of this because they, the availability of resources and things is much more limited out there. But so this lost a picture at the top, but that's okay. The idea being that like this is the notion of what system integration is, that it's coordinated, co-located, and quote unquote integrated. So this slide is the slide that I was going to come back to. Developed a tool by which you can, that's the IPAT, that you can use to kind of assess your program's level of integration. I put it up there as sort of one of these things where people can self-grade how well they're doing on the co-location, the integration, and the coordination. Now, before I go into a section on stigma, where I'm going to really kind of try to blow out the concept of co-occurring disorders, is thinking about this notion of integration versus coordination. I told you before, like some people have advocated for the idea that to treat co-occurring disorders, you need to have a multidisciplinary team that's co-located, seeing patients in the same room at the same time. I can tell you that I've been in meetings where we've had that, and you probably all have experienced this as well. We've had everybody in the same room, but all that's happened is those silos that we talked about before have now moved inside the room, and they're all in the same room, just the silos are in the room. The reason for that is because integration, in my conceptualization of this, integration around co-occurring disorders doesn't happen without coordination. And the coordination piece is the piece that's the interpersonal piece. That's the piece where you learn how to communicate with your colleagues, you learn how to understand the different nuances of your colleague, what your colleagues are bringing to the table, what the limitations are about what you can talk about, what they can talk about, and then coming up with strategic plans around, okay, if there are things that I can't talk about, how are we going to figure out how to be able to talk about these things? That you can't have integration without the coordination piece. And I'm bringing this back to the notion of co-occurring disorders, because it's in co-occurring disorders that we see this, or I see this happening the most frequently, is that there is multiple teams with multiple expertises in the same room, but unable to move anything forward because they haven't yet figured out how to communicate with one another in order to break down the silos that they've just brought right into the room with them. So that being said, I want to expand out the notion of what a co-occurring disorder is. We've talked about co-occurring disorder as sort of a substance use disorder or substance-related disorder and the presence of a mental health disorder. I want to expand that out and talk a little bit more about the fact that in many instances what we're looking at is co-occurring disorders also, again this isn't in the textbook, also include what I would call assessments and addressing issues related to stigma, discrimination, disparities in care, social determinants of health. So these are equally, if not in many instances more important when thinking about addressing co-occurring disorders and identifying co-occurring disorders. And we'll talk a little bit about what I mean by this. But let's talk about discrimination based on stigma. So this is from state of Wisconsin. Discrimination based on stigma is disqualification from social acceptance, derogation, marginalization, and ostracism encountered by persons who abuse alcohol or other drugs as the result of societal negative attitudes, feelings, perceptions, representations, and acts of discrimination. So how does this play out? What ends up happening, right? So there is a negative attitude or prejudice that is pervasive in society or pervasive in a healthcare system. What does that lead to? It leads to differential treatment. What does that lead to? When there's differential treatment, negative health outcomes. Okay, this is boom, 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 boom. That's where we see this. Now, where are you encountering people who are coming in with co-occurring disorders who are ill? I mean, by definition, in most instances, people are coming to see their doctors or encountering the healthcare system because there's a problem. They're not feeling well. Something's wrong. You're seeing them right here, where you could address some of their mood issues with Prozac. You could address some of their alcohol issues by prescribing naltrexone or putting them in CBT around relapse prevention. You can do all of these things. However, in many instances, especially when it comes to the addiction psychiatrist attention, is that people have already tried that and it hasn't worked, and people are scratching their head. Why hasn't this worked? What has happened here? In my experience, what has happened is that some of these other upstream issues haven't been looked at, examined, or addressed. Okay, so social determinants of mental health: discrimination, adverse early life experiences, poor education, underemployment, unemployment, poor access to healthcare, poor quality of built environment, food insecurity, economic inequality. These are the kinds of things that would be assessed when trying to look at those upstream factors, trying to take a look at sort of like what are these other factors that might be contributing to the negative health outcomes that we're seeing. So discrimination based on race. Race is a socially constructed characteristics based on physical attributes and ancestry. Racism is a set of social arrangements that translates the classification of individuals into a social hierarchy of privilege and opportunity. So how does stigma kind of stem from that? I co-did a talk with Martin Epson, by the way, who is a VA, also still has a foot in the VA, one of the CBOCs. And this was his slide. I took it from him and borrowed it with permission. Stigma. So where does stigma come from? Where does the concept of stigma come from? The concept of stigma comes from, and has its origins in slavery. It comes from ancient Greek and Latin and referred to a brand that was seared into the skin of slaves. So again, kind of coming back to this idea of thinking about stigma hand in hand with racism and hand in hand with negative health outcomes, and seeing that historically these have been related. Over time, stigma took on a different meaning, an additional meaning. Now it suggests an ugly mark you cannot see, a kind of invisible brand. Society often places it on whole groups of people, like the mentally ill, the homeless, and drug users. And again, this is sort of stigma that then gets incorporated within those upstream of factors that contribute to health disparities and negative health outcomes in the patients, practically speaking, the patients as they're walking into your office, plus or minus a mental health disorder. While that is helpful and effective in certain circumstances, in other words, it's very helpful in reinforcing, in some respects, the idea of silos, like that these are two different things, they're differentiatable, and it lends itself well to research projects. It lends itself well to kind of being able to, compartmentalize in a way. But remembering that clients are coming in not with this compartmentalized by themselves. They are seeing themselves in an entirety, and what's contributing to their mood being bad that might look like a depression? Well, there are things like stigma and racism that they're bringing into the room. There are these social determinants of health, food insecurity, for example. And one of the things I wanted to kind of emphasize, and this is sort of the cheerleading part of this, which I know is a no-no for motivational interviewing, from the standpoint of validation and affirmations, but the idea that recognizing that the system will tell you time and time again that you can't address these things, and that you shouldn't, in some instances, address these things together. And what I'm saying is that when you're now at the end of your boot camp, which means you're now at the beginning of the rest of the fellowship, but as you go through the rest of your fellowship, you'll learn about different specific interventions, you'll learn about different things that you need to know when you go out into the rest of the world. But when you leave fellowship and you leave training and you go into the rest of the world, I can tell you that the rest of the world is going to be looking to you for help with how to handle complex clients that happen to have a whole slew of different symptoms. And if you go in and you say, this is the example I give to people, I say, if you go in and you say, well, this is someone who has psychosis who's actively using methamphetamine, and you come in and you say, well, I'm an addiction psychiatrist, and I know I'm picking on the psychiatrist here. I'm an addiction psychiatrist. I'm going to look at this. I'm going to come up with a very sort of nuanced notion of sort of like, well, this could be primary schizophrenia for these reasons. This could be methamphetamine induced for these reasons. That's great, and you should be doing that. At the end of the day, you put that down, and the rest of the system is going to look at you and say, so what? What do we do? That's where you have to get creative. That's where you have to start thinking about, okay, if I'm going to be implementing concrete, practical things that the system actually needs or that people actually need to improve their symptoms, I may have to be looking beyond thinking about, or for that matter, even spending a whole lot of time thinking about, is this methamphetamine induced or is this schizophrenia? These are the symptoms that the patient's coming in with. If we want to impact this, we want to look at the system around them. We want to say, okay, are they housed or are they not housed? Okay, are they in a domestic violence situation or are they not in a domestic violence situation? Now, how are you going to address that? You're going to have to learn how to communicate with your social work, your other colleagues within the system, to kind of identify and communicate to them, like, listen, I've got these issues. I want to start systematically trying to eliminate some of the upstream issues and come up with an action plan. Then that's where people are then going to see your real value, is that you're going to be willing to go into the system and try to think about advocating for a broader view around what the co-occurring disorders actually mean and how to address them with a game plan. Another example of this, or another way of thinking about this, is thinking about I'll skip forward here a little bit, but it was a good one, and then it floated out of my head. But I've got another one. I'll come back to it. The other thing that I wanted to highlight, and again, I wanted to also kind of give a practical idea of what it means to be, or to start thinking creatively about how to address people that are coming in with complex presentations. One way to do it is the ICU approach, and kind of like, I'm gonna parse this out. And I think that that's one way it will become second nature to you, if it isn't already, to kind of think about things in sort of a problem-based manner. The other way to think about it is also thinking about, like, well, the problem-based approach, giving that back to the patient, isn't always going to be what they want to hear. They don't want to hear themselves compartmentalized. So just yesterday, I was working with a client who was complex pain issues, and as well as multiple different, what we would call, mental health diagnoses, bipolar, anxiety, depression. And they were really asking me questions about pain management. They're like, "What? I got these pain issues. What I want you to do for me is I want you to give me a list. I want you to give me a list of all the meds that can be used to treat pain." And I was like, no. Number one, because I don't have a list that maps all that out. But what I do want to do, since we have the time, is I would like to talk with you a little bit about pain, and talk a little bit about sort of like different components of pain. And all I did is I took the whiteboard and I said, and I'm not saying that this is the perfect approach, I'm not saying that there was a great outcome with this, but the idea was that in that moment I recognized that business as usual for addressing and answering their question and just giving them a list of medications is probably not going to lead me to the place that they want to be, or that I want them to be. And nobody's going to be happy with that in the end, because I could say, yeah, there's 1,000 different opioids, none of which are going to get prescribed, but nonetheless, there they are. But it says I need to look at this a little bit differently. I need to try to engage this client a little bit differently. And I just put 3 things on the board. I said, okay, there is, and I know it sounded a little bit technical, I said there's neuropathic pain, there's nociceptive pain, and there's emotional pain. And I said all 3 of these are related and can interact with one another. And then it gave a story. And I said, okay, I want you to envision a scenario in which there's 2 different people who are involved in the same plane crash, but the plane crash happens in 2 different places. Person A, the plane crash happens in New York City. They crash, they break 15 bones, they go to the hospital, top-notch care, everything gets pinned together, great, hunky-dory. Now you're in the hospital, you're watching reruns of Judge Judy for the next 6 weeks. Okay, sitting there staring at that and staring at your multiple pins coming out of your leg. I want you to think about what their experience of pain is. Now the second person, person B, same plane crash, well, not same plane, exact same injuries from a plane crash, but this plane crash happened in Siberia. And person crawls out of the plane, they're the only survivor, they look around them, and in the snow around them, because I presume Siberia has a lot of snow most of the year, looking around them, packs of wolves. Their experience of pain, same injuries, is going to be significantly different than the experience of pain of the person who's sitting in the hospital and staring at their leg. The reason I told this story to this particular client was because I wanted to kind of emphasize the notion, and I talked with them a little bit about the idea that the pain experience is contextualized by all these other factors in your life. So let's talk about some of those other factors. Let's figure out what the wolves are that are trying to get you right now. Or let's figure out what wolves are not trying to get you because you're standing in the hospital, looking at your leg and experiencing the pain without any distraction from that. Let's try to figure out what some of those other factors are that are contributing to the context that you're experiencing the pain. So all this to be said, one of the things that I've also advocated for with people in thinking about co-occurring disorders is this notion of that I mentioned there in passing, which is throwing out the playbook and saying that for certain highly complex clients, it is going to be necessary for you to not play by what the business says you need to play by, and think about coming up with creative alternative solutions. For the CL, I use my CL examples with this, which was perfect example. Guy gets admitted to the hospital. He's going to be there for 8 weeks because he's getting IV antibiotics. On day one, everybody knows who he is. He's screaming, yelling, throwing his IV pole, won't get dressed, poop everywhere, no discernible schizophrenia, at least, that we can see, from the distance that we're allowed to get to him, right? And psychiatry service gets called and says, what do we do? I say, okay, well, let's take a look at this. And we start talking with people. This was an actual case, by the way. Start talking to people, and in talking with the nurses, and in particular, the nurses usually have the best notion of what's actually going on. Talking with the nurses said, well, he just hates all of us. But Nurse Jane, he doesn't yell at. For some reason, he lets Jane go in. Jane's here like every 3 days. She comes in and and she does her shift, and those shifts are fine, and he behaves well. It's like, okay, well, so what's business as usual? Business as usual is that Jane keeps coming in every 3 days, and in the 2 days in between, this guy causes holy hell, throwing his IV pole and the whole 9 yards. So what are you going to do in that situation? Well, you could think about institutional changes. That's why my very last bullet point at the very end of my talk is talking about institutional changes. In order to get Nurse Jane, in order to get this guy through his hospitalization with minimal, injury to other people, let's think about how we can get Nurse Jane here, reassigned, because Nurse Jane apparently didn't have a problem with this either because he was treating her fine. How can we get Nurse Jane here? Oh, we can't do that. The union will get upset. This is the procedure. This is just how we do it. I said, well, just how we do it will have a predictable outcome if we continue to do just how we do it. However, if we think about maximizing or changing that and approaching the system and saying, and figuring out what approach we're going to take with the system to explain why we want to do this, we're more likely to have a better outcome. And that's what we did. And they got Nurse Jane there, and most of the hospitalization was without it. I mean, Jane couldn't be there 24 hours a day, 7 days a week, but we got longer periods with less disruption. Again, that looking at it and saying, like, is that it, when you open up the textbook on co-occurring disorders, is this what they're going to talk about? Probably not. But when you get out into the world and you're faced with people with complex, highly acute symptoms that are unstable and causing a lot of problems, and also to themselves and to others, is that this is potentially the space that you may need to occupy in the end, is helping to look at the system and say, where's my Nurse Jane? How can I bring it to the rest of the hierarchy to adjust business as usual so that we can better address some of these issues? Anyway, as per usual, I have offered a rambling diatribe that included several pontifications, several things that are not necessarily standard practice, and I'm open to criticism of these things as well. And commentary on this, I would encourage anyone who is interested, if you want to talk to me more, if you're starting your fellowship, I'm around. I'm happy to talk with people. I'm happy to have opportunities for people to we've talked about shadowing opportunities and things like that. So, and I think the psychiatry addiction psychiatry fellows will have opportunities to come up and hear more of my missives, provided that this talk hasn't completely alienated me from the
Just one more concrete example of the sort of problems you talked about, which you didn't mention, Jeff, although this is something that goes to your history clinically, is Jeff was very active clinical leader in the consult service at UCSF at Langley Porter for a couple of years. And I know because Jeff told me how frustrating it was for him when he wanted to treat addiction in the context of the Department of Psychiatry at UCSF at the main campus. He was told he couldn't do that because Langley Porter wasn't licensed as a facility that could treat substance abuse, as if that weren't a part of mental health.
I think I blocked that whole thing out. But yeah, it's exactly
You
right.
were just beside yourself with the frustration of that.
And we found out,
and learning that.
right, and we found out in the end that there really wasn't a licensing restriction on that. Anyway, thinking about institutional things, but thank you for reminding me. I had forgotten about that event or series of events. Yeah.
I'm gonna write a couple other examples similar to that and see what creative solutions you might have for them. So, as somebody who's now practiced primary care in the UCSF health system,
Yes.
where if I wanted a patient, so back up, at UCSF Health, in some of the sites, there's an embedded psychiatrist.
Yep.
They can only see people with private health insurance. They cannot see people with Medicare or Medi-Cal.
Boom.
So, if I had a patient who I needed help with for mental health issues that had private insurance, they could be seen by this person. This person had a personal want to care for people with different insurances, so she had a workaround of like, you would e-message her and like ask her about these things and she could communicate with you that way, but that was the only workaround. So what we then did is we had a referral to the social worker. The social worker would either call the patient or send them a list of different psychiatrists and psychologists in the area that they could choose to call or not call. I'm thinking about stigma in medicine. There's some studies looking at if somebody who sounds white, educated, on average it takes them about 8 different phone calls in order to get an appointment at a psychologist, etc. If it's a person who sounds like they're black or uneducated, that number goes to 50. So you can imagine, as you were mentioning, the number of trials and the tolerance of doing that can be really challenging. So anyway, folks get this list, or they get to go to TAPS, which is a center in CBHS, which is 1380 Howard in downtown. That's a little bit chaotic and has its own kind of vibe to it. So some folks will walk into that area and just say, no way, this is not a place that I feel comfortable or safe. And there's a waiting room and they go through an intensive process. And that's the only way that some people can see a psychiatrist or a psychologist. Now, if you're in the DPH system, which is where I'm now, it's all well, it's not all, it's like mostly Medicare, Medi-Cal. And there is a clinician and a navigator who are also located in the clinic. And the patient can see the clinician, who's a psychiatrist, for 1 or 2 visits for an assessment and to see how to link that person to care. And then there's a human that's a navigator who will also help link that person to TAPS or to these other different services. But as a primary care physician, it's just so unbelievably frustrating you hear about CBT or you hear about therapy and it's like, pragmatically, it seemed like there was no way for me to get my patients those things.
Yeah. I think that highlights exactly the issue. Also highlighting, I think to kind of put a little different spin on it, also highlighting the fact that in case you haven't learned it yet, you will learn it, which is that as much as we want to practice what we think is or what we would consider to be sort of just pure medicine, and like, I just want patients to come in, I'm gonna see them, I'm gonna assess their kidneys, I'm gonna do this, I'm gonna do that. As much as we want to be able to do that and not have to think about these other systems-based things, by and large, at some point during your clinical practice, you will realize that you can't do that. You can't function without understanding what the other parts of, well, you can, you just will become, you won't be as effective as you'd like to be. That in reality, so much of the system impacts how people's health, what people's health is, how good their health is impacted by these things that you have to identify those people within your system who really understand the system and listen to them and kind of start to pick their brain and pull their ear so that you can walk away with at least start to understand a little bit better about how the system works and why it is that someone with a particular, with Medi-Cal can't access services at this particular site, and then thinking about sort of systems-based interventions at that point and say, well, if we're identifying people that we know have significant behavioral health issues and we're doing the primary medical here, but we can't do the behavioral health piece here because the system is telling us that we can't do it here, then where does it, should this patient be having their medical care here? Let's think about, or if we need to send them somewhere else, or because the system is telling us this comes back to the coordination piece, which is that I have to advocate with my system to get an extra 15 minutes with each of these patients so that I can spend 15 minutes calling the behavioral health provider every week when I see this person. And on the health plan side, by the way, in my role in working with Partnership Health Plan, is that I've been advocating with them to create that space because they're looking at it and they're saying, gee, we can't figure out why these particular cohort of patients is costing us millions and millions of dollars. And then we talk to the primary care doctors, and the primary care doctors are like, listen, I know all of these problems. I don't have the space to be able to do the care coordination piece. And I say, well, that's actually something the health plan can help with. We can provide the clinic with funding to be able to get the space so that the primary care doctor can do the behavioral health coordination. Again, it's not integration, it's coordination. And, but again, those are, again, thinking about sort of creative solutions, thinking about sort of like ways of working around the system. That's another example of like, if what would I need to do this better? If what I would need to do this better is another 15 minutes that could be spent with a phone call that someone could line up for me, like a care coordinator could say that the behavioral health provider will be available at this time. My schedule's open, boom, 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 make the call, and then we can do a more close person-to-person coordination. Then you might find yourself less frustrated with the, like swimming with, I don't know what to do about this. So anyway, that's just an example of kind of trying to think about like, business as usual, 15-minute med appointment may not work with every client. And getting systems and getting institutions to kind of recognize that like, that's the case. There's going to be a certain cohort of patients that the 15-minute med appointment isn't going to work. Or you could keep doing it, or like, was it Einstein, like keep banging your head against the wall and expect a different outcome? That eventually someone will, we'll just stick with this course and eventually they'll catch on. It's like, well, $10 million later, you're still learning the same lesson. Anyway, again, my pontifications.
Thanks, Jeff.
Okay.